Great. Welcome everyone to House Healthcare. It is Friday, April 7th. I think I have this little date thing in front of me. We are going to have a committee discussion in S37. Fully aware that we have not gone through all the sections yet. But the sections we have not gone through are scheduled for next week. And so what I wanted to do is walk through some of the issues that have been raised, see where people are with needing more testimony so that if we do need more testimony, we can get it scheduled next week and move the bill as we are slowly running out of time in the State House this year. So I made some notes. So I'm just going to go through section by section and we'll take each one, jump in. Again, comments, we're not doing straw votes or anything today. I'm not looking, for support or don't support, just kind of, do we need something more than what we've gotten on each of the sections? Does that work for everyone? Okay. And then when we're done with this, we're done for the day. So on section 1 is the definitions, and we have questions around consent. And so Legislative Council is working on we're not going to go over it now, but they're working on providing us some information. This actually goes across a lot of the sections. And so we'll have them back next week and have conversations around that. And then there was the request by Mari to add, you said medications, other people have said prescriptions into the definitions for legally protected healthcare activity, right? Okay. Art?
When you say consent, what do you mean by that for sure?
So we were talking about
Parental consent?
18 VSA 8351, gender affirming care, what is already in statute today, what consent laws do we have? So we will have, they're pulling all that together and they'll come before us.
Okay, all right.
Do you think we need to define gender dysphoria and gender incongruence?
Thoughts? I mean, I think they're medical definitions. I don't think we do
Okay.
personally, but I don't know what others think.
DSM, there's the psychiatric.
A what?
Jessa, do you want to comment on that? Do you mind?
I don't mind. I can do it from here. Jessica Barnard of Vermont Medical Society. All right, either way.
Yep.
Jessica Barnard, Vermont Medical Society. Personally, I agree that those are more clinical terms and sort of defined in the clinical realm, and would probably prefer to keep it that way in case they do change based on changing sort of clinical information rather than having it defined in statute.
Okay.
Thank you.
That answers my question. Thank you.
Great, thank you, Jessa. Is there anything else on section 1? I will say I've heard from some folks, and maybe I'll ask, sorry, Jessa, maybe I'll ask you the question around the prescriptions and adding that. I think there's been some broad consensus that that would be okay. But we'll talk to Ledge Council as well, but.
The Jessica Barnard, Vermont Medical Society, we would be in support of clarifying that.
Okay. Great. All right, anything else on section 1?
I think it's clear, but I'm just bringing it up. Do you think we need to make a statement someplace in here that children under 18, the parents are involved? That's a question that I've been asked by several people.
How about,
Already
I thought that would be part of
already in
consent.
there.
right, I was gonna say, let's maybe wait until we hear on the consent piece next week.
Okay.
Let's add that to the list, so I will add that to the list. Okay. All right, so we can come back to section section one, if we need to. Section two is medical malpractice, which let's let council walked through. We received written testimony from Jamie Fian, who represents the medical malpractice folks, lawyers, I guess you would call them. So I don't have that in front of me, but it is on our website. And so they're in support. No one has come forward that isn't in support. So I wasn't going to actually have him come in and testify unless you all want him to.
Who's that, Laura?
So Jamie Fian is the lobbyist for, let me actually pull it up.
American Property Casualty.
The insurers
Oh, okay.
for medical malpractice. And so I know that, and it says in the letter, he worked with the Senate on the language and they are in support of the language. So unless people have concerns, I wasn't going to bring them in. Art?
I wouldn't mind having a second review of what abusive litigation means in terms of this bill.
So we are having Michelle Childs come in, who's legislative counsel, and she did H89. So she is coming in next week already to talk about the differences between the two.
Okay.
So we will make sure we get that answered.
All right.
Okay. All right, section 3. So section 3 is all, section 3, 4, and 5 basically go together. So this is all the insurance, so insurance for gender affirming care, insurance for abortion and abortion related services, and then the state plan amendment request. So Blue Cross Blue Shield, MVP, and Medicaid have come in support of these. If you remember yesterday in the testimony, both, all three already do what's in section 3. So, they started covering, at least Blue Cross Blue Shield started covering it in 2012. It was added to our essential health benefits in 2014. There is cost sharing. So that's that piece. And then section 4 is the abortion and abortion related services. Again, everyone said they do this already. There is the change to eliminate cost sharing for those who do not have high deductible health plans. And as Blue Cross Blue Shield and MVP both said, it's very, 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 very small amount of people who this would actually help. Art?
I had a note on mine on paragraph C on page 7, the cost sharing, asking about premium.
Yes.
It doesn't list premiums here in terms of them going up because of this.
Right.
And I assume it isn't in there on purpose that premiums can rise.
Right. Premiums can always rise, but the testimony yesterday was that they have been covering these services since 2012.
Oh, yeah.
So they testified yesterday, they don't expect an impact on premiums because of this legislation. If they did, and we've done this before, where we put things in legislation where it will impact premiums, they usually come in very clearly with estimates of what the impact would be. And, they said there would be none. Any questions or anything else we need to hear from on that? Yeah.
I had also asked Blue Cross Blue Shield to get us some cost information comparing when they first started covering services in 2011, 2012 to now. But they did say that it was a small percentage of people in services. Yeah.
And I think they also said, was this around the comment where they made, well, if someone is going to see a mental health counselor for gender affirming care, it might not be.
It won't be coded
as gender affirming care. So it's hard to really, yeah. Okay. So you're good there. You don't need anything else from them.
No.
Okay. Alan?
Just a kind of goofy question here. Anybody that goes in for services at abortion or abortion-related services, if they have no insurance whatsoever, what happens then? Does Medicaid step in, or do the providers, gratuity thing, or?
I don't know.
Well, CPIMS falls under Jennifer Carby.
Yeah, thank you.
If somebody comes in for services and doesn't have any coverage, it falls under either the free care policy. If it's a hospital, they may provide services to the person depending on, for free or for reduced cost, depending on income. But ultimately, the patient is responsible to pay out of pocket.
Right.
They don't have coverage.
Yeah.
There's no,
But they can be turned down?
as long as it's not an emergency.
Emergency, yeah, if it's elective and not emergency, yes. There is a nonprofit in Vermont that I think provides funding for abortions, but that doesn't fall into this. But yes, they could be turned down if it was an elective procedure.
And if they were involved with a community action agency, because they were low income, community action agency is going to see what they can do about making them eligible for Medicaid. Or any other service agency.
Right.
State agency as well.
All right, we're good there. All right, so section 6. I know OPR are in support of this, but did have some questions. Our mental health providers included in the definition of healthcare provider. We heard from legislative counsel on that. And then they will be working with legislative counsel on some potential language changes that they would like to see. So we'll have them back in next week as well.
Another question.
Sure, Mari and then Alan.
I had wanted to be able to talk with them while they're here about scope of practice issues.
Yes.
And to hear them talk about the process for disciplinary action, which is different state by state and different depending on the profession.
Yes, that's around section 8, correct? Around the pregnancy crisis centers?
Yes.
Okay. So yes, we'll have them in. I think we might have them on the schedule twice, but
Okay.
yes, we'll do all that, but let's talk about
That
that.
should be for everybody.
It is.
It will be, yes, we're gonna, so let's hold on section 8 for a second. Alan?
Just explain it to me, I guess. I still don't quite understand why these providers don't have to be in a compact to provide their services.
You mean, so,
I'm a little ahead of myself here, but I just got, okay, these providers do not have to have a license cross state lines like all the other compacts we had.
yes. Do you want to?
So these provisions are around what our state licensing boards would do for Vermont licensees or applications for a Vermont license. You don't have to participate, I can't say it, in a compact to get a Vermont
License.
Right.
license. And so we're really looking here at statutes that apply to our regulators of Vermont licensees and applicants for Vermont licenses.
So that's just Vermont.
Licenses.
But they can practice across state lines.
I mean, if somebody has a compact
Follow, yeah,
license or is licensed and somebody can have a license in multiple states, they can get directly licensed through multiple states.
Right.
But these two sections are really just dealing with the kind of.
I know, and that
disciplinary
just,
actions.
it just made me think of that. That was a question I had.
Yeah. Does that make sense?
Yeah, Will.
A little? Anything else on really section 6 or 7? Because one is for OPR, one is for Board of Medical Practice, and they're the same language. So I suspect we'll be hearing back about some potential changes in language there. All right, chapter 8, which is the pregnancy centers. So we heard that the Attorney General will come back with some suggested language that will make this apply across all pregnancy centers. We do need to review the findings still. We skipped that when we did the walkthrough, so we'll do that next week as well, the findings in this section. And then we will have OPR in and have them kind of talk through the licensing process and you know, how that all works with centers.
Credentialing.
Yep, yeah. Art?
To me, 2491 on page 11 has no business in the bill at all, in my opinion. We didn't hear anything in testimony that supports it. I have a real problem where it says Pregnancy Service Center fraud. I think at the very least, the word fraud should come out of there. But I don't see why this is in here. I don't even think it's germane to the purpose of the bill. So to me, that whole thing should come out.
Okay, thanks, Art. Anything else in section 8?
This is another topic, but this is not about this section, but I just was concerned, and I don't even know how to just advise. The idea that if you get free services, that there's no consumer protection. How do we think about that?
So we think about that in the language that
It's not really that-
Attorney General has put forth.
Yeah.
That's not really our
It's not our purview. Whose purview is it?
Commerce.
commerce.
So, but is there a pathway through, I mean, I talked to Stephanie this morning because it's a concern. I don't know, but okay. Maybe someone can help me think, maybe you can help me think.
I can help you think about that.
I think there's a
outside of
summer
this.
project.
Yeah,
Say that again?
There's a summer project on it.
Oh,
it's a lot of summer
well,
projects.
that's good to know. If I know
Volunteers in the
someone,
parking lot.
so if I know that that's happening, I feel better.
All right, and I'm sorry, go ahead.
I guess, Lori, this section, to me, I would need help just sort of from you clarifying like how much of this is going to be in the parking lot in terms of our concerns. My concerns are largely around regulation and drawing a clear line of what healthcare services are and what are not healthcare services, and making that really clear in order to reduce healthcare risks to Vermont residents.
So I think that is a very much bigger conversation than what we are having here. And so my intent is that we work within what we have here, have the conversation with OPR. And then, you know, it's something that if people want to come back with a bill next year, or we just no bill, but we just want to take some testimony, we could do that next year.
So I think in number 6, Pregnancy Services Center, where it has the appearance of a medical facility, if 2 of the following.
I'm sorry, I need you to, number 6.
14.
Page 14.
Yeah. In section 6, maybe section isn't the right word.
Okay, row 8.
12. It starts on 8, but where it says has the appearance of a medical facility, when we looked at the website, they did offer testing and diagnosis, and they did appear to have a staff who wear attire of, you know, because there was a photograph of someone with a stethoscope and a white coat. And I'm just wondering if that means that it is a medical facility and therefore subject to our medical laws.
I would write down that question for OPR.
Okay, so that's the question for me for OPM.
That'd be great, because if you read their reviews, if you go on the website and read the reviews, one of the reviews responses from the organization says we provide medical services and then lists them. And the M was capitalized. So that's how they're speaking about themselves. So I just want to put that as like interesting how they're also communicating about themselves.
Just out of curiosity, because I don't know, what does Planned Parenthood do in their advertising and what they actually do in the building?
Would we like to have?
I don't know what,
I was wondering about that actually.
hmm?
Thinking about Planned Parenthood and, but they're a medical facility, they are licensed, they have board certified practitioners, and that's how they present themselves.
I don't know.
I mean, that is a fact.
Would you like to have Planned Parenthood in? Might be helpful.
I think we should.
Yeah, I think it's a good.
The only reason I ask is there's some pretty strong statements there. And I know there's gonna be a battle, so we might as well find out where they are, what they do, and then the questions hopefully will be answered.
Okay. All right, we'll get them in
Distinction between the two.
between the two. We will get them in. Bobby?
Yeah, to add to what Topper's saying, I mean, if we could see the regulations that apply to Planned Parenthood, and I don't know if it would be appropriate for this bill, but to say that if you're gonna call yourself a medical facility, they have to follow the same regulations, or they have to have some kind of disclaimer, like everywhere they put their name, like, we are not a medical facility, we provide counseling services.
Right.
I mean, I think that would be a fair thing to say to prevent the confusion.
Right. Okay. Great. So we'll bring Planned Parenthood in and OPR, but again, I want to be really clear that with the time we have left, like, let's start those conversations, but we just can't, because we will be making changes to this, you know, even if it's just adding the word prescription or medication. So then it has to go through our process, and then it has to go back to the Senate, and they have to go through their process, and that's come back, you know, in order to finish before we leave in 6 weeks. All right.
Well, and what you say, Lori, to me points to the problem with this section. I don't know why it's in the bill at all. I get, and I don't agree, and that's fine with a lot of stuff in here. But this section, speaking of to back on Bobby's, what he just said, it really belongs in another bill in another committee, because these are things that involve legality and things like that I think are beyond this committee. I just don't think Section 8 belongs in the bill at all, really.
So from my perspective and what we heard from testimony from the Pregnancy Center Aspire Now, and what you can see on their website, they look like they offer abortions. And only in very, very fine print do they say, and they don't even say, we don't offer abortions. They say something else. And so if we go back to what, you know, deceptive advertising is, that's deceptive advertising, in my view. And one of the reasons that it is in here, because it does deal with reproductive health, which is the purview of this committee.
I disagree.
Okay.
Thank you.
Yep.
Also, I think there are sections in the bill around professional conduct of healthcare providers, which seems to me to follow.
Yeah, I mean, really, it's reproductive health, and that's in the purview of this committee. Anything else on Section 8? All right. Section 9. So Section 9, you know, one of those sections you think, oh, this is going to be super easy. Was not super easy. So this is the section where we had AHS in talking about the community profiles, and we had Green Mountain Care Board in talking about the health resource allocation plan. I talked to the sponsor of the bill, which is also the chair of health and welfare in the Senate, that had this bill. And their intent, I think, is what we thought it was, which is they want to be able to look at access in the state and determine gaps. So they ran out of time and did not have AHS testify on the community profiles piece. And so I think from my perspective, hearing from AHS that the community profiles is grant funded, it's not state, you know, it's all communities have to agree on the same thing. The data isn't exactly current. I don't personally, but I would love to hear everyone else's comments. I don't think it's the best way to get to gaps in the system. and that really the HRAP plan is the best way to get to those gaps. So I'm going to put out there that we take out section 9A, leave in B, and potentially, and I look to Ledge Council to know how appropriate this is, to add some type of language that says what we're trying to do, which is assess gaps in the system of reproductive health. But then that also leads to another discussion we had of defining reproductive health care and gender affirming healthcare in this section to make sure, we're getting to what we're want to get to. That, does everyone think about that?
So if I could add,
Go ahead.
So I think that makes sense. I think in my mind, there are two different conversations. And the one that I had the most difficulty with the testimony from AHS around whether if we were going to keep the community profile in, I would feel adamantly about keeping the word shall,
Right.
because of the argument I made about historically disregarded communities of people. So that's one conversation. If the conversation is about what works better, it would be more effective. I think I could be talked into just removing the community profile part, as long as the Green Mountain Care Board HRAP process, if we think that would be effective enough to meet the concerns that I had, not using shall in the first section. Does that make sense?
Yep.
So the first section will be gone, but we will say shall
For Green Mountain
for Green Mountain Care Board. Yes.
It's already in.
Yeah, we'll keep that the same.
Yeah, I'm not suggesting that we change that or that we were going to, just that as long as the Green Mountain Care Board will be effective in what we're saying it will do, as far as my concerns about protecting historically.
Protecting or
Including, sorry, yeah.
Okay,
Including, which is
Right.
also protecting because we're not leaving them out of
Right,
the
okay.
conversation.
okay. So we can get some clarification around Green Mountain Care Board. I would actually have to go back and listen to their testimony again, but in talking with Veronica and the executive director, Susan Barrett, they were comfortable with this language and thinking they could get to what we were getting at with the information they had available. Now, we may find in a year from now it's not sufficient and want to do something else. That's always a possibility. But
My main concern would be that communities in Vermont would have equitable access to resources around gender affirming care and reproductive health care services, or that we would know where there were gaps so that we could address them.
yes, so I think that we should potentially put something like that in this. I'm looking to Jen and Ameren so maybe we can work on that with them and then look at it next week.
Okay.
And send it to Green Mountain Care Board and make sure they're comfortable with it.
Okay.
Leslie?
so I'm interested about removing AHS from the equation. So that's what we're doing. So what are the implications of that?
Well, Green Mountain Care Board is responsible for the health resource allocation plan.
HRAP, and I was
Right.
reading through that, so I think I understand that. So if I'm hearing Mari right and you right, then we're gonna get the information we need from Green Mountain Care Board. We don't need AHS involved in order to get that information. If it comes out of AHS, it doesn't give it more power as opposed to Green Mountain Care Board. I'm just trying to
So
understand.
just remember, Green Mountain Care Board is a separate entity from AHS, so AHS has no, authority over Green Mountain Care Board. And so these are technically two different pieces. So AHS was charged with the community profiles. Community profiles really isn't the best way to get to this information. So remove those, right? AHS doesn't have authority over Green Mountain Care Board.
No, and that's not what I'm saying. I understand that. I'm just wondering if we lose anything by removing AHS. But I'm hearing that you don't think we do.
I don't think we do.
That's what I'm trying to figure out.
I don't think we do.
Because it was originally included, and I understand and I hear you that they ran out of time and didn't explore it and blah, blah. But
Well, not only that, I mean,
included for a reason, so I
Right.
try to understand that.
It was included because from my understanding and talking with the senator, it was included because they thought that was a viable way to get the information. But as soon as I said it's grant funded.
In
And
fact, it's not.
it's, and it's looking at it, it's just really, communities like you and I in the community could go onto a community profile and see something where we'd have to know a little bit more to be able to like see what's in the HVAC plan. So we're losing a little bit that way, but I don't think we're losing much because I don't think it would really give us what we wanted anyway. That makes sense. Daisy?
So if it's grant, it's an indicator. To me, there's a way that you can implement this tool and use it to inform progress, blah, blah, blah. But I also think it's something that ties into and sort of reflects progress of the programs that we're funding. And I think without this tool, we're removing one of the ways that we hold the administration accountable for collaborating, right? And so I feel like we should not remove this. I think that it's, removing AHS from the equation, and, equity is one of our principles that I think we all value. I think it's something that our communities deserve. And I think this is a mechanism by which we can monitor it. And I think it's great if Green Mountain Care Board is a willing partner in being able to lift up this information. But I think the piece that I fear we might lose is that this connects directly into the programs that AHS is doing. And they have really robust grants from CDC, so much data. And I just fear that, this is already connected to those programs. All the data is there. I would love to see this tool continue to lift that data up and have that transparency available to the public.
So we're not getting rid of community profiles. We're just saying community profiles don't have to include information at this point on reproductive healthcare services and access to gender affirming healthcare services.
I understand that.
Okay.
I'm saying I think they should.
Okay. So what if, since we heard testimony that it has to be consistent across the communities and AHS does not feel comfortable with a mandate, they may decide not to include it anyway.
I'm saying I think they should.
So you would like to issue a mandate?
I'm saying I like the language as it was initially drafted.
Okay. So we will come back and take a straw poll on that at some point in the future. Leslie?
So I was also confused, and maybe you could help me with this about the community profiles, because the data was way old. Yeah, 2011, 2015. So how do you sold the community profiles anyway? I mean, if they're dependent on grants, it doesn't appear that they're considered important enough to use. I mean, I don't know how a community would use that kind of data as it stands.
I would ask AHS about that.
I did, and Shayla didn't respond in any amusing name, but you know what I mean. I mean, she didn't really address it. She basically said, yeah, we don't do it. It's not being done. Okay.
How about if we ask Shayla to come back and ask her, tell her what we want, and see if she can figure a way to collaborate with the Green Mountain to get the information we're looking for. Is that too much of a lift?
Well, no, it's not too much of a lift, but I think we're looking at two different tools here. So we don't necessarily need AHS to collaborate with Green Mountain Care on HVAC. They have that data. I mean, that is data that they have. They will be able to produce, hopefully what we're trying to get to here, which is gaps in the system.
Yeah, but I thought the Agency of Human Services, when the plan was written, I thought they had some part in making sure that the resource allocation plan was in fact done, implemented. It doesn't.
Annual.
It's an annual, it's already in statute that it's an annual. Do you want to? Sorry, could you repeat that?
HRAP.
HRAP.
Wasn't a done thing, it's done, they update it.
They do update it, it's not, for the record, Amber Navarrete Legislative Council. It is updated, but it's not updated within a specific time frame. They add into it more over time as there are certain projects or areas of services that they need to look at. And it's sort of it's an ongoing project, but not necessarily updated at a certain interval in time.
And under the purview of Green Mountain Care Board with nothing to do with AHS, or does AHS have a hand in it?
So it is managed by the Green Mountain Care Board, but the Green Mountain Care Board uses data sets from different entities within state government. So they do pull information from other departments in state government to help inform that work.
Why don't we do this? Why don't we have the Green Mountain Care Board back in, talk to us a little bit more about HRAP and how they would expect to be able to meet our intent of this language. And we will have someone back in, probably not Shayla, who can talk about the community health profiles in more detail.
Can I just clarify?
Absolutely.
So Davey, are you trying to get at, because I think I understand what you're trying to get at, is that, I mean, you want AHS to actually take action and use the data that's being procured to create an action plan. Is that?
No, I just agree with the language as it was written when it came to us.
Okay.
I think they should add that to the community profiles.
Okay, I'm just wondering if they use the information from the Green Mountain Care Board to inform their own work, if we could, instead of having two different entities collecting, that we just sort of require that one collects and then the other needs to include that in their assessments, their community action.
No, I think the data is already there. Green Mountain Care Board already has it because it's claims data, right? They're looking at the health services, they're looking at CPT codes. And I think DIVA has that too.
Mm-hmm.
I don't want to overthink it and the mechanics of it. I think they're the experts on it. They can figure it out, but I agree with the language as it is. And I also think that because it is indicator data and because the language of it under the community health profiles, I think that it ties into accountability as it does with when you look at the other indicators of the community profiles. And I think it's good that that is built into the programming at AHS. It ties into their other RBA stuff. And I think that's one of our goals.
All right.
And I tend to agree with Representative Rebecca about holding agencies, departments, offices that provide services to people living in Vermont, all people, that we hold them accountable. And I also am feeling unconvinced that the community profile process is, from what I know, what I heard in testimony, I'm not sure how effective it is.
That's what I think.
So I think that's an issue in itself.
Well, so there's question around this. I think what we need to do is do what you said, bring the people back in and deal with it.
Another thing this just made me think of is we did a tremendous investment this year for an upgrade on the MRIS.
Yeah.
What's it called? The MIGS. It was 18 million just.
It's an acronym that starts with an M. Yeah.
Diva's here.
MDAS.
Yeah,
MDWAS, yes. And so, I'm thinking along those lines of using technology and these huge investments we're already making in technology to kind of increase our transparency and also sustainability for these other providers, right? Like it helps the state ultimately because we can, the greater access people have to looking at where the gaps are in services, the greater access people have to other funding sources ultimately.
And I completely agree with everything you are saying. I'm just not sure community profiles is going to get the data, is going to do that. But I agree with what you're saying, and we have to get to that somehow. So let's have them both back in and figure out how we best get to that.
Yeah.
Yeah.
I just wanted to suggest that if we're gonna bring people back, considering the time crunch, if we're gonna bring people back, that maybe we could all think about what we want to know before they come and send them a list of collated questions. So like they get the 10 questions of different committee members in advance. So when they come in, they can just present that versus us interrupting them every 5 minutes and asking questions. And not that that's a problem like in some situations, but I think considering there's very specific things people want to know. And I'll think about that too, but it's just a suggestion to make it easier for everyone and including the witness.
And I will be talking, because of the time crunch, to everyone we're now having come in to make sure that they understand what we're trying to get to. But if you want to send me questions, please definitely do so. All right, that one. Yes, I'm sorry, Leslie, you did have your hand up.
Yeah. Didn't Cheryl say she was gonna send us some links about community profiles? And
yes,
I haven't seen that.
Oh, it's only been a day.
Oh, I don't know, whatever.
But yes,
that's, maybe that's something that you could help us with, just because then we can understand how much value it has or not.
Yeah.
And that's sort of the question, because of the old data, and if, I'm thinking about being a member of a community and trying to understand my community with this data, and does that help me?
Right. Okay, so we're moving on. Section 10, OPR had requested to change the date to 2025, since most of our compacts that we just passed and are still in the Senate, so they may not even get out, don't start until 2024. So I think that seemed appropriate, and I think that was the only comments I had. I don't know if anyone has comments on 10 or 10A.
Lori?
Yes.
Just a quick question on, and it maybe isn't in this piece, but out-of-state telehealth licensure and registration. All right, it doesn't apply to this, I guess, but back to Alan's question a bit on licensure. And Jen answered the question, but I forget who we had, the gentleman on the screen talked about the fact that these two, abortion and gender affirming care, were two activities that we weren't licensing for out of state. What did he say? And I apologize for not understanding it totally, but he specified that those two things were problematic to him in a way because of and it's not the telehealth, it belongs in the other.
Was it the board, was it David Hurley and the Board of Medical Practice? Yes. So his concerns were, hopefully I'm paraphrasing this, you can always watch the testimony again, but from what I remember and what I wrote down, his concerns were that, we've practiced in a manner across the country for many years where, states have the sovereign right to regulate within their borders, right? And that there was, and I'm probably not using the right legal language, so jump in. There was, a commitment or a recognition that if, we needed assistance from another state, they would potentially provide that in whatever type of lawsuit or something might be happening around a license, right? And that this is changing those established norms.
Okay. So it's nothing in law, it's just
It's established norms was the language he used.
To get a license or to?
No, not to get, well, potentially if someone's applying for a license, but no, just in, I can't think of the right words. Reciprocity.
Okay.
There's a filing, that someone did something in a state and they're going to try and pull their license. Other states might provide information,
okay.
Right?
We would pull a license.
Really not.
Okay. Okay, so
But
I
those are
think
just
I understand.
established norms, and what we're saying now is, Vermont will now disregard that, right? So, if Texas wants to come after someone licensed in Vermont because they did something that they felt was against their law, but it's not against our law.
Help them and we won't hold them to that standard.
Correct.
Okay.
Did I say that all right?
Okay.
And I remember him saying that if we then turn around and have a problem in another state going,
Right.
ask them for it, we will not be given the same.
They may say,
Okay.
forget it.
Yeah.
Too bad,
Yeah.
right? We're not helping, you didn't help us, we're not helping you. Right. Right.
So this is committee discussion, so this is an appropriate time to talk about this a little bit, right? So I actually am concerned about that, because, and I don't, not to be too negative, but like, I feel like this is the beginning of the dissolution of the United States, because what we've operated under this, like, idea that each state has sovereignty, and then like we work together, but there's certain freedoms that each state has, and then we help each other out. And under what we're about to do, I could be wrong, and lawyers could jump in and be like, you're totally wrong, or you might be like, no, you're right, is that if we pass this, then let's say a Vermont provider decides that they're going to be renegade and they're going to provide gender affirming healthcare to someone in, I don't know, what's one of the states that banned it? Tennessee, Indiana. Indiana is saying they're going to cut all gender affirming care for people by the end of the year or something like that, dramatic. So let's say like Indiana, people who are in the middle of gender affirming care are like, oh no, I'm going to have my hormones cut off. What's that going to do to my body? And a Vermont doctor says, I'm going to help you anyway, even though I'm not licensed in Indiana. Like you can do telehealth with me, whatever they do. And they want to go after that doctor. And our state's going to say, no, we're harboring a fugitive. Even though in our state it's legal, in your state it's legal, we're harboring a fugitive. My concern, though, is number one, that undermines like this sort of integrity of the United States as a nation. Then number two, what are we going to do when parents in Vermont are paying people out of state to do conversion therapy on their kids in Vermont? And then we want to hold them accountable, and the providers in another state in Indiana says, oh, well, too bad. You hand over the doctor who gave hormones, and we'll hand over the doctor who did conversion shock therapy or whatever. You know what I mean? So like the point is, I feel like this is very concerning to me as a citizen of the United States. And like, I'm concerned that this is the beginning of like, I mean, maybe it'll be good for us. Maybe we do need to break into separate states or regions or something. Maybe we're too big of a country, but I feel like this is the beginning of like a civil war that doesn't involve bullets and guns, but involves like pills and syringes and therapy. If that makes sense. I know that's a little dramatic, but I mean, it's like, and I don't know if a government person could say it as dramatically as I could, because, they're not allowed to or whatever. But like, that's as a elected person, I am concerned that like, I still think we need to protect people. I'm not against it, but I'm concerned about where it's going, because what's going to happen then down the road is this the start? And then next thing you know, it's going to be other kinds of crimes that like we're not helping. So someone does something in Vermont, goes somewhere else in Indiana, says, too bad, someone killed someone in Vermont, but you won't hand over the doctor that gives hormones. So we're not handing over this murderer. Like, where is it going to stop? And I don't know.
So I have some comments.
All right. I'm sorry if it's too dramatic.
Let Alyssa go first.
Oh, I'm sorry.
For the record, Amber Navajo, Legislative Council. I just wanted to clarify that in terms of S37, in the scenario, the example that you were giving, there's nothing in this bill that would allow Vermont to harbor the provider. It would say that Vermont is not going to discipline that provider's Vermont license for what they did, but would not stop the other
That's
states.
helpful.
from
Okay, that's helpful.
And if they leave the state, I mean, there's, this is just saying that.
H89, there
Right.
is additional.
Yeah, I was gonna say, you will hear from Michelle Childs, who is working on H89. There are some provisions in there that do relate to how our state entities, including our licensing boards, may need to react to requests for information around civil actions or criminal actions from other states, from providers providing services that might be illegal in those other states. So there's more on that. I don't think I would say that bill is harboring necessarily, but you will hear more information there. So I think a lot of your concern here might be looked at in the lens of H89, whereas this is really focused just on the how we discipline a Vermont license.
That's helpful to know.
Yeah.
Do you still want to comment? Or you?
Yeah, I just wanted to.
I do too.
I'm gonna say, Brian's doomsday prophecy. No, what I'm sort of seeing this as is, because I sort of, I fight with I wrestle with this section also in just the same way.
This section or this bill?
This section in particular about, not to use the word harboring, but it's really not. It's just that we're not going to remove that Vermont license from that provider. Indiana can do whatever they want with that provider's Indiana license. We're just not gonna follow suit with the Vermont license. But to me, I sort of am thinking of this as, medical care. These professions have changed, and I don't think we're keeping up with the way they've changed. And to me, I'm thinking about how we can move away from the long established norm of why does the care follow where the patient is located. And I think things like this might get to be points where states start looking at, is it really where the patient is located, or is it where the provider is located? Or what is your license? What boundaries are there of licenses? Just because you have a patient who you have been seeing for 20 years and they go up to Disney World, this belief that somehow we can't treat somebody's UTI over the phone because they happen to be in Florida and you don't have a Florida license. I'm thinking, it's the rethinking of what care is and how it's delivered.
The site code.
Federal legislation, it sounds like.
Well, isn't that kind of what compacts are?
Yeah.
That's kind of what compacts are, but compacts still follow where the patient is located.
It's just allowing it to.
It's just.
Maybe it should be both, wherever.
Maybe it should be both.
Marty?
There are some areas where I think it would be helpful, and I'm speaking about the concerns that you brought up, which I hear. I think there are some issues in this country where it would be better if there was a national process, a national system, and it goes from universal health care to just all that encompasses what is healthcare. And I think we've seen fundamental attacks on evidence-based medicine, on science over the last few years, and against widely accepted standards of practice by people who have many years of study and research. And the fact that some states are throwing that out the window because some individuals or individual groups think that they have better ideas is harming people. And so I would characterize our response in this state not as we're beginning a path down not respecting the sovereignty of other states. We are responding to what is already happening, and it's a response. We're not starting it. So there are national standards, there are national accrediting boards for a reason. We want people that live anywhere to be safe and protected and be treated by healthcare providers that follow standards of care. Best practices, good quality research, not junk research. So we live in interesting times, and we're having to respond because dangerous things are happening elsewhere.
Leslie?
If I may, I think we are challenging the sovereignty of another state by this because we're saying we're going to do this in spite of what you say, in spite of your law. And I think we need to because we need to protect people. And I'm thinking from what you're saying, and I know you think that there's some drama, but I'm agreeing with it, let's go to the 1850s. I think that's in a lot of ways the dialogue that we're starting here. And that's scary. And I know this isn't applicable to this bill, but you brought it up and I've read some about it. And we're at a time and it's important that we protect people in our state.
So, and I want to be clear, right? We are protecting people in our state.
That's right.
We are not telling
Yeah.
other states we don't, like,
But we are going to be treating people from other states. And we
providers will be making that choice.
We are protecting.
For making that choice.
Protecting our providers.
In
And that's the
Vermont.
right thing. Yes.
In Vermont.
In Vermont.
Yes.
Their law is different.
Fine,
Yeah.
but we are protecting them in Vermont. I just want to be clear, as our comments are on YouTube forever. I want to be clear, we are not, putting something out to other states. We are simply saying, if you have a Vermont license, we are protecting you in our state. Brian?
I just want to say I understand that. And like, I don't think that we're starting it. I think we're responding to something. It's more, so my concern is more about what's happening nationally. The fact that like the humanitarian crisis we're going to be facing soon nationally in healthcare because of the actions of other states. So I just want to be like, I don't think we are starting it. I do feel like we might unintentionally escalate it. And at the same time, we have to defend people. So and I guess my bigger concern isn't like us protecting healthcare providers and the people of Vermont. It's that, is this the next step going to be an onslaught of people from out of the state practicing illegally in the state on telehealth, doing conversion therapy, things like that? And then when we are like wanting to protect people under those conditions, Indiana's going to be like, we're not helping you. You know what I mean? Like, and that's more what I'm worried about is like where it's heading, not what we're about to do. I feel like I will support this and we're doing our due diligence to make it as good as possible. I do also want to validate what I'm hearing from some of the people who oppose this, because we are other states have taken action to like undermine the rights of the individual, but that there has been over time actions by the government to undermine the rights of families. There has been, like I've seen it. And so I just want to acknowledge that. So like it's complex, the issue. Yeah. And I just want to honor that. And so I'm hoping we can keep hearing from all people so that everything we do is we do our best to honor the rights of the individual, but also do what we can to help support families and being healthy and thriving, because our society has set it up so families fail. I just think socioeconomically, like I see it over and over again. And then when the state swoops in, it doesn't help. So I don't know. Just want to put that out there too.
So I'm going to rein us back in, okay?
Well, this is a discussion. So it's
rein us back in. It's a great discussion. No. It's a great discussion. It's a good conversation. There's a lot that this taps into. I just also want to state, we are not the only state that is doing this. We are not the first state to pass this type of legislation. So we're not, we may be one of a few, I don't know how many, but we're not the first. So we are looking at what other states have done. So as long as you're not taking us way out, what did you?
Oh, I was just thinking that if there weren't those laws, we wouldn't even have this. So we are responding to what's going on.
Yeah, totally.
Yeah.
It's total response.
It's important to understand that it is a response.
Yeah.
It's defensive.
We wouldn't need to do this if that wasn't happening.
Okay, so we've gone through all the sections we've gone over. So we'll have sections 11 through 14 next week, just to confirm. We will have Legislative Counsel Michelle Childs come in and talk about H89, which will help answer Art's question around abusive litigation. We're going to reach out to see if Planned Parenthood can come in and talk about what they do and how they advertise. We're going to hear from Legislative Counsel in the room, who will talk about our consent laws today. And we're going to have folks back in on section 9, so we can make a final decision on that.
When did you say we're hearing about consent laws today?
No,
Okay.
next week. We'll finalize the agenda today and we'll post it.
So is there more this afternoon for us, or?
No, as soon as we are done, we are done.
But we should come ready next week to dig in and get the rest of the work done.
Yes.
Okay.
Gosh. Perfect.
All right.
Yeah, and we'll also continue S47 next week. And and for those who are new, this is a point where, we eventually will also start receiving bills that we pass to the Senate, that they are now looking at, that will come back. For instance, I just testified this morning on the radiology assistant bill. They are making an amendment to it. It will come back. We'll have to review it. So, things get a little kind of jumpy and all over the place over the next couple of weeks, but we're going to keep moving forward with the bills we have to get out, and then hopefully have time for, I know, some things that some committee members want to look at. So Leslie and then Art.
So I'm just looking at H89, and I found it hard to read because I don't understand the legal language. And I didn't see that there's maybe a summary somewhere that maybe you could point me to help me understand the bill.
We have to ask Michelle.
Okay.
I don't know if she's prepared one or not.
Yeah, and if she hasn't, I think my intent, at least with Michelle, is she is not walking through the bill. She is coming to provide us a summary of what it is.
Okay.
And how it does or doesn't interact with ours. So there may not be anything, at this point, I'm not going to ask her for something, but if there is.
I was just wondering if it was out there and I didn't see
I will,
it.
I'm asking her if she has one. If she has one, I will.
I appreciate that. Thank you.
Art.
I wondered, Lori, what other Senate bills? We've got the two we're working on now. Is there another one that has been sent to us?
So the only other one that has been sent to us that may cross over is S65, but there are two Senate bills in judiciary that they have custody of right now, but we will probably do a drive-through or take possession of S89 and S36. Okay, so there's still quite a bit of work to do. Hey, Brian.
I just
You about that after?
I just got an email that the Senate wants me to go talk about H481. So people should I just saw it. So people should just know that they're, looking at our.
Yes, they are definitely starting to look at our stuff. So, good, because I just talked to her about that this morning.
Yeah, and I just got the email right now, so I figured I'd put it out there like that things are moving along with that too.
Great, thank you. All right, we are done for today.